Hey everyone, welcome. If you're prepping for your medical boards, you already know that parasites can be an absolute minefield of obscure facts and tiny, easy-to-miss details. Trematodes in particular are notorious stumbling blocks just because of their incredibly complex life cycles and, honestly, bizarre intermediate hosts. Today's explainer is basically your high-speed cheat sheet. We're going to master the rogues gallery of trematodes, also known as flukes. By the end of this explainer, you're going to have a rock-solid mental framework to completely bypass those tricky examiner traps and ace your boards.
So here's our roadmap for today's explainer. We'll start with schistosoma, the blood flukes. Then we'll cover their clinical phases and pathogenesis. Next, we'll hit the foodborne liver flukes. Take a look at fasciola, the outlier fluke, and paragonemus, the lung fluke. And finally, we'll wrap it all up with the high-yield exam traps.
All right, let's jump right into section 1, schistosoma, the blood flukes. Now, unlike other flukes, these guys are hiding directly in the human bloodstream. This is a fundamental concept for your exams. You've got to be able to instantly tell these three species apart based on where they hang out and what their eggs look like. Think of the egg morphology as their literal fingerprint. Monsoni loves the inferior mesenteric veins and has this very prominent lateral spine. Hematobium, it prefers the vesicle and pelvic venous plexus, basically think the bladder, and sports a sharp terminal spine. Then there's Japonicum, which hangs out in both the superior and inferior mesenteric veins, and it's the smallest egg with just a tiny lateral knob. And you know, those spines aren't just for show. They actually help the egg physically tear through venous walls and adjacent tissues to exit the body. Because of where the adult worms live, Monsoni and Japonicum tear their way into the gut and leave via feces, while Hematobium exits through the bladder wall right into the urine, which classically causes terminal hematuria.
Okay, pause right here. I absolutely have to hammer home this counterintuitive exam trap. The tissue damage in schistosomiasis, it's not caused by the adult worms. Nope, it's caused by the eggs. Just imagine the host's immune system detecting these highly antigenic eggs trapped in the tissues. The body totally freaks out and mounts this massive, aggressive Th2 immune response. We're talking IL-4, IL-5, and IL-13. The immune system is desperately trying to wall off this foreign invader, right? But in doing so, it builds this massive, destructive granuloma. It's actually that inflammatory response that ends up destroying the surrounding tissue.
Moving right along to section 2, clinical phases and pathogenesis.
To really lock this in, let's trace a typical patient's journey chronologically. Let's say we have a patient who just got back from a trip where they were swimming in Lake Malawi. Day 0, right exactly where the cercicaria physically pierce their skin, they might get swimmer's itch, a super distinct, intensely itchy maculopapular rash. Fast forward about 2 weeks to 3 months, and our traveler enters the acute phase known as Katayama fever. Now here is the absolute kicker. Katayama fever happens predominantly in travelers, not in the folks who actually live in those endemic areas. It's this severe, serum sickness-like antigen-antibody complex reaction. The patient is going to walk into your clinic with spiking fevers, profound eosinophilia, and transient pulmonary infiltrates. Then, over months to years, as the infection becomes chronic, we hit the intestinal and hepatosplenic phases, which eventually lead to some really severe urogenital or neurological complications depending on the species. Now, in that late hepatosplenic phase, which we mostly see with Monsoni and Japonicum, you get this thing called Simmer's clay pipe stem fibrosis. It's a mouthful, I know. Basically, the trapped eggs trigger intense periportal fibrosis. Think thick collagen deposits forming right around the portal vein. This mechanical roadblock causes severe portal hypertension, massive splenomegaly, and really dangerous esophageal varices. But listen closely, because here is a massive takeaway you've got to remember. Examiners will try to trick you. They'll describe a patient bleeding from esophageal varices to bait you into picking cirrhosis as the answer. Don't fall for it. Unlike standard cirrhosis, the hepatic function in these patients is beautifully preserved. It's strictly a pre-sinusoidal block, meaning the liver cells themselves, the hepatocytes, are totally fine.
Now, if we look at the late phase for schistosoma hematobium, things get incredibly dangerous in the urogenital tract. The classic presentation here is painless terminal hematuria. If you do a cystoscopy on this patient, you're going to see what we call sandy patches. These are actually heavily calcified eggs and dense, fibrous tissue literally embedded right in the bladder wall. And this perfectly illustrates exactly why hematobium is an IARC Group 1 carcinogen. All that chronic, relentless inflammation leads directly to squamous cell carcinoma of the bladder. And keep your high-yield differentials in mind here. Standard, everyday bladder cancer is usually transitional cell carcinoma. So if you see squamous cell carcinoma of the bladder, boom, flashing red flag for schistosomiasis.
All right, Section 3, foodborne liver flukes.
Let's pivot and compare two really closely related culprits, Clonarchus sinensis and Opisthorchis viverrini. These are distinct liver flukes found in different parts of Asia. Clonarchus is mainly seen in China, Korea, and Vietnam, while Opisthorchis is highly prevalent in Thailand and Laos. But here's the crazy diagnostic trick. If you're looking at their stool under a microscope, the eggs from these two species are completely indistinguishable from one another.
So how exactly do humans get infected? The classic vignette is a patient eating raw or undercooked freshwater fish that's loaded with metacercaria. Once ingested, these flukes go on a totally wild physical migration. They travel through the duodenum, literally crawl up the ampulla of Vater against the flow of bile, and just set up permanent shop deep inside the intrahepatic bile ducts. Heavy infections cause severe cholangitis and mechanical biliary obstruction. And, much like hematobium cause bladder cancer, these guys, Clonorchus and Opisthorchis, are group 1 carcinogens. They carry a massively high risk for cholangiocarcinoma, a truly devastating bile duct cancer. If you catch it early enough, though, the go-to treatment for both is praziquantel.
Moving along to Section 4, fasciola, the outlier fluke.
I like to call this one the outlier fluke because it basically breaks all the rules of the typical liver flukes we just talked about. While Clonorchus and Opisthorchis need that freshwater fish host and heavily drive up cancer risk, Fasciola hepatica. It doesn't even have a second intermediate host at all. The metacercaria just stick directly to aquatic plants. Humans usually catch it by eating contaminated watercress, a lot of times in sheep raising areas. Plus, and this is highly, highly testable, Fasciola has absolutely zero association with cholangiocarcinoma. None. It presents a completely different clinical picture, focusing way more on acute liver tenderness during the migration phase rather than long-term oncogenesis.
Okay, Section 5, Paragonimus, the lung fluke.
This next pathogen requires a total diagnostic pivot when you're evaluating a patient. So let me pose a direct question to you. What parasitic fluke classically mimics tuberculosis with a recurrent cough, fever, pleural effusion, and night sweats? Think about your differential for a second. Got it? The answer is Paragonimus westermanni. You pick the sneaky one up by eating raw or undercooked freshwater crabs or crayfish. And the larvae have an absolutely wild migration route. They penetrate the intestinal wall, physically bore their way right through the diaphragm, and end up in the lungs. Once they're there, they create these cystic cavities in the lung parenchyma. If you glance at a chest x-ray, those cavitary lesions look exactly like active tuberculosis. It's a brilliant exam trick. But the absolute dead giveaway for Paragonimus is the sputum. Patients cough up this rusty, bloody sputum, which gets its thick brownish-red color directly from iron-pigmented eggs. And, keeping with the trend, it's effectively treated with praziquantel.
And finally, Section 6, high-yield exam trats. Let's bring it all home with a rapid-fire review of clinical vignettes to lock in the absolute most tested traps. First up, you absolutely have to know your eggs. If the vignette describes a patient with a terminal spine egg found in the urine, that's hematobium. A prominent lateral spine isolated from the feces, that's Mansoni. And if they mention the smallest egg with just a tiny lateral knob, you're definitely dealing with Japonicum. Seriously, strictly match the species to the morphology.
Trap number 2. Examiners love to catch you slipping on acute Kazuyama fever. Just remember, this severe serum sickness-like reaction happens almost exclusively in travelers who are encountering the schistosome antigen for the very first time. It is super rare in chronically exposed residents of endemic areas because their immune systems have essentially modulated the response over time.
Trap 3, Simmers-Clay pipestem fibrosis. Yes, it absolutely causes massive portal hypertension, ascites, and esophageal varices, but whatever you do, do not confuse it with cirrhosis, because it is a pre-sinusoidal block. The hepatic function, meaning your transaminases and synthetic functions, remains completely 100% preserved. Trap 4 is all about keeping your cancer associations crystal clear. Schistosoma hematobium causes squamous cell carcinoma of the bladder. On the flip side, the foodborne fish flukes, Clonorchus and Opisthorchis, cause cholangiocarcinoma of the bile ducts. Do not mix up your oncology associations here. For Trap 5, when a question zeroes in on Schistosoma japonicum, remember that it's uniquely dangerous. It pumps out the most eggs per day. It's highly zoonotic, meaning it hides out in animal reservoirs like pigs and water buffaloes, and it's the schistosome most likely to end up in the brain. That can cause cerebral granulomas, which lead directly to new-onset epilepsy. And finally, our pharmacology trap. We've seen that praziquantel is basically the wonder drug for almost everything we've talked about today. But there is one massive exception that the test writers are praying you forgot. So, Which specific organism requires triclobenzidol? The answer? Fasciola. Praziquantel is completely ineffective against Fasciola hepatica. You absolutely have to use triclobenzidol. Master these exceptions and you are for sure going to ace the trematode sections on your boards. But, as global travel ramps up and climate change actively alters the habitats of the snails carrying these flukes, we really have to ask ourselves how long before these historically tropical diseases become commonplace in our very own local emergency rooms. Thanks for tuning into this explainer and happy studying.